This conference will now be recorded.
Roll number 117. Sirisha. Am I audible for you?
Yes, ma'am.
Okay, today our topic on discussion is acute diarrheal disorders. So as this is a clinic session, there will be interaction with everyone. Last time 1 to 10 people have presented the case. So I'll start from the number 11. Number 11. Roll number 11. Roll number 12. Roll number 40. Roll
Yes,
number
ma'am.
40, Pavan. So what is the definition of diarrhea?
Frequent stools.
So only frequency is important, nothing to do with consistency.
Consistency also.
Consistency is also important. Then how much frequent? Is it 10 times or is it 1 time? Is it 20 times or how much is the frequency? Okay, diarrhea is defined as passage of loose or water stools, typically 3 times in a 1 day period. That is more than 3 times, along with change in the consistency also. Frequency is only one frequency is not important. Frequency plus consistency. If the child passes normal hard stool 3 times, it is okay. So loose or watery stools for more than 3 times in a 24-hour period, we call it as diarrhea. Roll number 80. Roll number 80. Roll number 27, Sandeep. Roll number 27.
Yes, ma'am.
Okay, can you tell me some of the causes, etiologic factors of diarrhea? So next definition is on acute diarrhea, but that is less than 2 weeks of duration. So what are the causes of diarrhea in an acute phase presentation? So can you tell me any infections?
Typhoid, ma'am.
So typhoid, you should tell the organism name.
Salmonella type.
Very good. So salmonella. Roll number 1, Manvita. Manvita. Roll number 80, Jayashri.
Ma'am.
Yeah. Any other etiology? Do you know any other etiology? Any other organism other than salmonella?
coli.
Very good. E. coli. Any other? In E. coli, you
Shigella.
have two forms
Shigella.
like, very good. Shigella also. Shigella, will it cause dysentery or diarrhea?
Dysentery.
Very good. Shigella usually causes bloody stools. And E. coli, you will have two forms like enterohemorrhagic E. coli and entero-invasive E. coli.
Invasive.
Okay. Any other? 127 Dharani. Dharani. Roll number 127. If you don't answer, I'll mark absent. '62 Prasanna Kumar. '62 Prasanna Kumar. '86 Amar. Roll number 86. So 62 and 86 both are absent. 69 Amruta. '69. Chandana 101. Chandana 101. Roll number 15 Shweta.
Yes, ma'am.
Yeah.
Ma'am.
Any other organisms? Any other organisms do you know?
Acute diarrhea, ma'am.
Diarrhea. If you know, tell yes. Otherwise, tell no.
No, ma'am.
So Campylobacter. All these are the organisms: Salmonella, Shigella, Campylobacter, and E. coli. All these organisms can cause diarrhea. So persistent diarrhea, it is of 2 to 4 weeks in duration, and chronic more than 4 weeks of duration. Dysentery, it is characterized by frequent small stools containing visible blood, often accompanied by fever, presence of any fever or severe abdominal pain, and tenesmus. Prolonged diarrhea lasting for more than 7 days or 7 to 14 days. So how do you assess? You'll do a just physical examination. You'll assess the general appearance, hydration, systemic examination, and extra-intestinal complaints. So first you will ask the child to drink. If a child is presented to a ER room, you give the child a glass of water and see whether the child is thirsty or able to drink or not. If not able to drink, the child is in severe dehydration, and if the child is drinking poorly, it is in a mild dehydration. But if the child drinks eagerly, the dehydration is moderate type. So this is one of the main distinguishing factor between a mild and that is no dehydration and severe dehydration. So this is the diagram depicting the signs of dehydration. You can see the sunken fontanelle in less than 18 months old age group, and the eyes will be sunken and dry without any moisture. There will be reduced level of consciousness, and mucosa of the mouth will be dry mucous membrane. Reduced tissue turgor. If there is a skin pinch, it will be more than 3 seconds. And capillary filling time. Those are the secondary presentation. That are the systemic manifestations. Generally, when you want to assess, you should see the fontanelle, you should see the tears, mucosa, and skin pinch, and presence of urine output present or not there. So oliguria or sudden weight loss. These are the initial presentations. When the dehydration is much more severe, and it involves the systemic also. The dehydration is much more severe and it leads to tachypnea. Due to lack of fluid, it leads to respiratory distress. It lands in respiratory distress or shock. You will have a poor pulses, you decreased urine output, tachycardia as an initial manifestation of shock, tachycardia, BP will be low, and due to peripheral vasoconstriction, you will have capillary filling time will be more. CFT prolonged. All these are signs of severe dehydration. So assessment of hydration status in a patient with diarrhea. You'll see the general condition. In no diarrhea, the child is very well and alert. In some dehydration, the child is irritable or restless. In severe dehydration, it will go into an unconscious state. Eyes will be normal in mild no dehydration and sunken in some dehydration and very sunken in severe dehydration. Thirst, drinks normally. Eagerly, the drinking is present only in some dehydration and unable to drink because the child is unconscious in severe dehydration. Skin pinch, it will go back quickly in no dehydration. Slow skin pinch in some dehydration and very slowly. It goes back very slowly in severe dehydration. So hydration status, if the patient has no signs of dehydration and no dehydration, 2 or more signs, then you call it as some dehydration, and 2 or more signs, that is also in severe dehydration also with decreased urine output. And treatment plan A, B, C, we will discuss it later. So in dehydration, look for the eyes. The first picture depicting the shrunken eyes and second one is the normal eyes, and the child is active also in the second diagram, and in the first diagram the child is lethargic or almost unconscious state. This is the method how you do a skin pinch. You want to pinch the abdominal skin, and you will see how much time it will take for the recoil of the skin. Usually it will be less than 3 seconds, and if it is more delayed, you call it as severe dehydration. See, in acute severe dehydration, how the skin pinches there are even after removing the finger. So management of the child, you'll do a general assessment of the child, and you'll assess the hydration status, and you'll give the appropriate fluid for prevention and treatment of dehydration. So you will correct, next you will correct the, first you will give the fluid. If the child is in shock, first you want to give the fluid. After that you want to collect the electrolytes and acid base imbalance. So after that you want to give proper feeding to provide normal nutritional requirements. After that you want to give a zinc supplementation. You treat the associated problems, and you give nutritional rehabilitation to the child and health education for prevention of diarrhea. So in the previous diagram, we have seen the skin pinch. In what conditions the skin pinch will be, you cannot measure the skin turgor, and it is not a definitive sign of diarrhea. Roll number 105, Sanjusha. Roll number 105.
Yes, ma'am.
So almost in every case of diarrhea, you can see the skin pinch, but in what condition you cannot take it into consideration?
Malnourished.
Very good. In which type of malnourishment? Both forms or only one form severe. Of malnourished child?
Severe acute malnourishment, ma'am.
Okay, SAM child you can't take. In a marasmic child also there will not be subcutaneous fat, right? So
yes,
if there is no fat, there will not be recoiling only. And in kwashiorkor yes, also, what will happen in a kwashiorkor child?
Edema will be there, ma'am.
Okay, in a kwashiorkor child, edema will be there. So can you assess the dehydration in a kwashiorkor child?
No, ma'am.
You can't assess, you can't make the skin pinch in a kwashiorkor also.
Yes, ma'am.
So in malnutrition, you should not assess the nutrition based on the signs. Roll number 25, Sandeep. Roll number 25 is absent already. Chandana, are you present or absent? Previously also I have called you. 101, Sai Chandana. Roll number 80 is also absent. 80, are you there?
Yes, ma'am.
Who's that? Jayashri. Okay. Can you tell me the pathophysiology of diarrhea?
Ma'am,
What will happen? First of all, there will be loose stools. What will happen after that?
gut and small intestine mucosa will be damaged.
Can you repeat? I can't hear you.
Small intestine mucosa would be damaged.
Okay, small intestine, that is in the infectious causes like enterohemorrhagic intestine will be damaged. I'm asking the pathophysiology. If there are loose stools happening, what is the what happens to your intracellular volume?
Increased, ma'am.
So if you lose water, your intracellular volume will be increased.
No, ma'am, decreased.
If there is intracellular volume and intravascular volume, what will happen to the intravascular volume?
It is also decreased, ma'am.
If the intravascular volume is lost, what will happen?
Reduced blood supply.
Okay, that is in the later
Shock.
phase.
Dehydration will occur.
Okay, that is in the later phase. Along with the water, what are the electrolytes lost in a diarrhea?
Sodium chloride.
Very good. Sodium chloride and also anything, any other electrolytes are lost? '64 Satyasri. Satyasri.
Yes, ma'am.
Yeah. Can you tell me the pathophysiology of dehydration? Already half she has completed. Like if there is water loss and electrolytes are also lost. What other electrolytes are lost?
Sodium, ma'am.
Okay,
Magnesium,
sodium and
ma'am.
chloride we have already told. What is the other common electrolyte?
Magnesium, ma'am.
More than magnesium, which
Potassium.
very good, Hamaya. Potassium, sodium, potassium, and chloride already she have told.
Chloride. Yes, ma'am.
Any other? Why there will be respiratory distress in a case of diarrhea? '30, Anusha. 30.
Ma'am,
Yeah, Anusha. Why there will be respiratory distress in a case of diarrhea?
alkalosis, ma'am.
Alkalosis or acidosis?
Acidosis, ma'am.
Okay, how that acidosis have come?
H plus retention.
What is lost, first of all? Is it retention or losing of some other substance?
Bicarbonate loss, ma'am.
Very good. Bicarbonate will be lost. So what will happen?
Metabolic acidosis,
If
ma'am.
very good. So it is not the retention of H plus, it is loss of bicarbonate more plays a role. So metabolic acidosis will occur. Okay, what is that breathing called as?
Kussmaul's breathing.
Very good. Kussmaul breathing. Can you explain that breathing type? What is that respiration? Kussmaul breathing.
Deep.
Very good. Deep and sighing. deep sighing, respiration. Okay. Roll number 45. Srinath, roll number 45. Srinath, roll number 101, she's still in absent phase only. Chandana. Roll number 101 and 45 both are absent. 69 Amruta. 69. First you respond. "45, 69. 49 Manoj Reddy. Roll number 49. 136 Nikhil. Nagendra, penny untado? Absent asina. Roll number 136. I'm marking you absent if you don't respond. So 101, 45, 69, 49 and 136 all are absent. Manoj Reddy. "128 Banu. 128. Roll number 75. 135 Karthika. 135. I'm really marking absent. Those who have not responded, I'm marking them absent. "75 Sai Suhas. Priyanka, 58, roll number 58.
Yes, ma'am. Yes, ma'am.
Okay. Okay, very good. So coming to the pathophysiology of dehydration, already they have told about sodium, and sodium is also lost, and already they have told about potassium and bicarbonate. So if sodium is lost from the intravascular volume, what will happen?
Wow. Fluid loss will be there, ma'am.
So what will happen to the oncotic pressure?
Decreases.
The fluid will run from the intravascular volume to
Extravascular volume. It will lost from body, ma'am.
You have committed correct only. If there is no oncotic pressure, that will lost from So what will it land it into? The baby will land into?
Shock. Shock.
Very good. What are the signs and
Hypovolemic.
symptoms you will observe?
Tachycardia.
Okay, tachycardia.
And dyspnea.
Okay, tachycardia and what else?
Mm. High.
Already in the previous diagram, I've told you one thing about your peripheral vasoconstriction will occur. So there will be
BP decreases, ma'am. Blood pressure
okay.
decreases.
Very good. Tachycardia and one is your low BP and any other thing.
Thready pulse, ma'am.
What are okay?
Pulse will be
Pulses
slow.
will be feeble. Okay, very good. What happens to the CFT?
CFT.
Capillary refill time.
Increases, ma'am.
Very good. Capillary refill time will be increased. And one more thing, what will happen to the urine output?
Decreases, ma'am.
Very good. If there is no intravascular volume only, how can water be pushed to the kidneys and how can they excrete? There will be decreased urine output and all these symptoms will be present. Very good. Roll number 110. Sai Krishna 110.
Hello, madam. Present.
Yeah, Sai, what will happen if the potassium is lost? What will happen?
Hypokalemia, madam.
Okay, what will happen? Hypokalemic. What is the complication?
Arrhythmias, madam.
In a GIT, in a diarrhea case. Definitely arrhythmia is there, but in the later phases, before that. Any type of paralysis have you heard?
No, madam.
Hypokalemic periodic paralysis. The motility will be lost. So this is the pathophysiology of your diarrhea. So roll number 66, Abhignya. Abhignya? Roll number 66. Roll number 110. He's already, already I've told, no? Okay.
Yes, madam.
Hello, ma'am.
Who is that?
66 months.
66. Okay, Abhignya.
Yes, ma'am.
So how do you manage the child with a mild dehydration? What do you want to give the child with a mild dehydration?
ORS, ma'am.
If ORS is not there, the child is in home and there is lockdown outside, what do you want to give first?
Home management.
Anything like home visit therapies?
Water mixed with
Water with
salt.
how much salt? Can I put one box full of salt in that?
No, ma'am. 2 spoons.
2 spoons, amma. Then you will go into hypernatremic dehydration.
1 teaspoon.
Pinch of salt.
Okay. Pinch of salt.
What you have told spoons is for sugar. So ORS solution of recommended composition, solution made from sugar and salt. We can either drink in a plain water or you can make buttermilk. You can make a soup from the rice water and kanji and or plain water also. We can use all these. And what is the physiological basis is sodium passes into the epithelial cells by co-transport by SGLT1 protein. So from that epithelial cell, sodium is pumped out by active transport through sodium potassium pump to the extracellular space. So this the protein use energy from the sodium gradient to transport glucose also into the cell. Again is the glucose gradient. GLUT2 uniporter that transport the glucose across the membrane. So in this dehydration, you can expect glucose hypoglycemia also. So coupled active transport of sodium and glucose in the small intestine results in passive absorption of water and electrolytes. That is why ORS includes both sodium and glucose also. So when a child comes to you with no dehydration, you can manage him even at the home also. They give, if the mother is breastfeeding the child, you ask the mother to continue feed. If you give more fluids than normal also, it will be recovered. Bring the child after 2 days, or if any danger signs are there, you can bring it immediately. The danger signs are high grade fever, irritability, the child is going into comatose stage, thirst is lost, and repeated vomitings, repeated purge rate, and bloody stools. Everything you can take, and lethargy also you should bring immediately, and give oral zinc for 14 days, 20 mg for 14 days. So management of some dehydration by plan B. So plan B, you have to replace the ongoing losses 10 mg per kg per ORS per each stool, and deficit replacement like 50 to 100 ml per kg. That is 75, roughly you remember, like 75 ml per kg over a period of 4 hours. You give 75 ml per kg. You take ORS, calculate 75 into 3 kgs. If it is 3 kgs, 75 into 3, and give it over a period of 4 hours. Daily requirement of fluid. Again, you have to give daily maintenance fluid as per Halder-Sagar formula, and zinc supplementation 10 to 14 days. If the age is less than 6 months, 10 mg, that is 2.5 ml zinc will contain 10 mg, and the age is greater than 6 months, 20 mg, 5 ml you have to give. So for each stool, if the child is going for stool, you have to calculate 10 ml per kg. You have to give after each stool. And deficit replacement, the 75 ml per kg should be going on only for 4 hours. And daily maintenance also should go on as per Halder-Sagar formula. And reassess after 4 hours. If still dehydrated, plan B is repeated, and any other food and milk should be added. If there are no dehydration signs, then you should go for plan A. You should re-escalate and you should go for plan A. And if the child presents in shock or there is not successful, you have to go to plan C. Plan C, if infant is less than 1 year or infant is greater than 1 year. So RL, the solution is best preferred is RL. And if it is less than 1 year, 30 and 70 formula. 30 and 70 are the formulas used. If it is less than 1 year, you want to give it slowly. So 30 ml per kg, you will take 1 hour time, and 70 ml per kg in next 5 hours. If it is more than child is more than 1 year, bigger child, you can give rapidly 30 ml per kg in half an hour, half of the time, and 70 ml per kg in the next 2.5 hours. This is for improvement every 1 to 2 hours. If not improving, give IV infusion more rapidly. And if they encourage oral feeding, same time, if the child become consciousness, you have to encourage oral feeding only 5 ml per kg per hour along with IV fluids. After 6 hours and 3 hours, assess hydration status, and accordingly go for plan B or plan A. If completely normal, you can go for plan A, or otherwise you can start with plan B. So this is how you treat the acute dehydration child. So roll number 101, 45, 69, 49, 136, 75 and 128 I am marking absent as they have not participated in the clinics discussion. Others can save your chart and leave.